1 hour of pure mathematics. Are you ready?
Only a question.
Okay, so thanks again, Christophe, for giving this talk, who is in the clinical field of electromagnetic source imaging and hemodynamic response in epilepsy.
Okay,
Right.
thank you. So you're almost done with me, 1 more hour. Thanks a lot. So I'm going to show this talk, which is summarizing a bit of most of everything we are doing in the lab, not everything, but a lot of aspects, and combining mainly 2 modalities. So I will continue on EEG source imaging in epilepsy, and I will show you also what we can do when we put EEG inside the fMRI scanner and how those 2 informations are complementary. So, so this is, I will introduce you the main modality. I will show you first how we can validate what we have when we have intracranial EEG. In the second talk, I will show you how we can validate when we know the surgical outcome and we have the surgical cavity. And in the last part of the talk, I will try to show you what we can do when we don't record any epileptic activity. So if there are patterns from resting state and networks that are useful to understand the epilepsy disease and within that context. So multimodal. So these are the 2 main modalities that we are using. So I talked a lot about EEG and MEG this morning. I'm going to talk briefly about that one, which is measuring EEG in the worst ever environment where you want to record an EEG, which is an MR scanner. As you know, you are measuring electric activity with electric wire. And if you move wires inside a huge magnetic field, you're going to get lots of artifacts. But we know how to handle that. And actually, so you need to record outside. So basically, you have an amplifier that is MR compatible, but the recording station is outside and connected through an optic fiber. Here, these are sandbags because you'd like to avoid vibration in the wire as much as possible. And because any small motion or vibrations will create of electric wires in an MR will create noise. So I won't go into details on how we clean those data, but the idea is that we get a very, for instance, when it's gradient artifact, it's a very reproducible artifact, so we can average it and remove it. The second main artifact that we are handling with is what we call the ballistocardiogram, which is at each heartbeat, you have a little motion of the head, which is creating a huge signal, and there are different techniques to solve that. So here the idea is you record EEG, you clean your EEG, and then we're going to mark those epileptic spikes that I showed you this morning for source imaging. And then as long as you mark the spike, you're going to look 5 seconds later to the hemodynamic response associated to that. So you are building an event-related fMRI design where your events are informed by your scalp EEG. And you can do actually the same to study sleep using EEG fMRI. And so this is some work we've been doing with Dr. Jean Gottman, and these are works from him, these are data from him. And actually, when you do that kind of things, you get a map like that, and you get a lot of response, spatially distributed. Some are positive, some are negative. And so you are really highlighting a network. And what has been shown by several studies is that if you look at all these hemodynamic clusters, so showing a change of blood flow 5 seconds after the epileptic charge, then the one that is the most significant, so the best SNR, if you want, is probably the most interesting statistically and clinically. And that's what they show in this study, where you see that when you have concordant result, it's mainly when you have when the difference between the 2 first clusters is high and when you have the highest t-value. So we're going to summarize it like that. So we're going to look at the fMRI cluster showing the maximum t-value, the maximum hemodynamic response. So we're going to summarize this fMRI map by only this cluster and show that it makes sense. And this is another study done by the group of Jean Gottman, where they then looked in the SEEG signal, so intracranial EEG signal, and they confirmed that usually what you get is the earliest activity you get in electrical activity. It might be not the one you record from the scalp. It might be even deep, but this is hemodynamic. This is metabolism. So even if the activity, for instance, is starting deep in the brain, like in the hippocampus, propagating in few milliseconds to the cortex, you see it from the EEG, you localize it, but the hemodynamic response will remain stronger at the origin, so in the hippocampus. And that's very interesting, even if the signal that you measure was propagated a few milliseconds later. And this is what Jean called the spike onset zone. So we're going to use that, and we're going to compare that with source imaging. So I showed you already that in epilepsy, we are dealing with spatially extended generator, and I show you this morning. So we hope that when we record an epileptic discharge, we have few square centimeters of cortex that are active, and we develop this MEM technique with Jean-Marc, and I will not repeat that. I showed you that this morning. So as a method that is sensitive to the spatial extent of the sources. So this is exactly what I showed this morning. Okay. So we have a method that's working well, that seems to be sensitive to the spatial extent. And what we did to get something a little bit similar to the best cluster in fMRI, actually what we are doing is we are not dealing with one localization only, but we are doing several localizations. Actually, when we record a patient during 1 or 2 hours, we mark several spikes. So we're going to do single spike localizations. You get a bunch of maps, so 20 spike equal 20 maps. And then we're going to do hierarchical clustering out of those maps. And we're going to get the cluster that has the more similar spikes. And this is what we're going to call a consensus map. So in a way, we have a similar approach by the two modalities. In EEG fMRI, we take the spatial cluster with the most significant result. And in MEG, we are getting the cluster where all the spikes localizations are more similar. And in this earlier study, we showed that doing that and fusing EEG MEG was very accurate. This is the spike-to-spike reliability you see with the fusion in the green label here for the different patients. So we get good results. So we know that we localize well. Now the idea is to validate that. So the first things we're going to validate with one of our gold standard, perhaps not perfect one, but at least it's which is in situ measurements of those electrical activity using intracranial EEG. So in this study that was recently published in Neurology by Dr. Shifau Abdallah, so what we did, we selected patients who underwent EEG and MEG, and then EEG fMRI, and then all those patients have been implanted during their presurgical evaluation using intracranial EEG. Everything was localized, co-registered to the same MRI, which is not that easy, but I passed the detail on that. So we included patients, we were showing a well-defined focal and seizure-onset zone defined in the SEEG. And we excluded patients with not enough spikes or with artifact or no post-implanted MRI or CT to localize the electrode. So in this study, we included 17 patients. So as I said, for EEG MEG source localization, we use the method of the fusion and consensus map, published by Chowdhury in 2018. For fMRI analysis, we show the most significant bold cluster. And then we used, because of course these are not simultaneous recordings, so the neurologists pick up similar spike. Of course, we are not comparing left spike in one modality to right spike in the other. We selected the same discharge. And then our gold standard was the intracranial EEG implantations. And there, so Dr. Abdallah, our epileptologist, defined visually on those where is the seizure-onset zone, which is the area where the seizure is starting and early propagate, and where is also the what we call the primary irritative zone, which is where the spike, those little discharges are generated. So those two regions might overlap, but they are not strictly the same. And then we propose a quantitative comparison. So the first thing was to put everything into the space of SEEG data. So what we propose here is to convert our MEG signal on the scalp as virtual intracranial EEG data. So to do that, we did 2 steps. We first applied our favorite MEM method to have 3D reconstruction along the cortex, and then to know what information from that, because SEEG is a very nice gold standard, but only where you have intracranial EEG electrodes. We cannot say anything where we don't have electrodes. So the idea was to project our finding into the SEEG finding and into the SEEG space. And to do that, what we did, we applied an SEEG forward problem. So in a way, we are measuring MEG in picotesla, reconstructing source in nanoampere meter, and then applying an SEEG forward problem. So we estimated virtual intracranial EEG potential in microvolt that we can compare with the real one. These are not simultaneous recording, but these are similar measures. So we can now compare our virtual MEG estimated potentials with the real one. And they have the same physical entities. So this is an example with a patient with an orbital frontal focus. So you see the MEG reconstruction here, you have the SEEG here, and I will just show you the average spike. So here you see the average spike that was actually recorded on that patient using mainly the orbital frontal electrodes, lateral one, and that was propagated to deeper one. And this is the signal we are reconstructing from MEG. So it's not strictly the same, but we have some nice correspondence between those two. And so in this study, we use that technique. So I will show you how we did it from the method point of view. So we first select similar spike in EEG MEG and in EEG fMRI, apply MEG source imaging, apply fMRI analysis, extract the most significant cluster. So these are our 2 functional non-invasive data. And from the SEEG data, intracranial data, we did 2 things. We marked intracranial spike, so we could average them, and we analyzed seizures. And from the seizures, so we defined visually the seizure-onset zone, and we also defined the most important sensor in SEEG, and this is using something called the epileptogenicity index. There are 2 schools to estimate that, either Marseille or Grenoble. We're using the technique from Grenoble here. So that's where we start. So this is a schematic representation of the implantation. So you have the different electrodes, so right amygdala, right orbitofrontal, and so on, and all the contact. The standard in SEEG is that small numbers indicate deep contact and then more lateral contact. And here we defined in orange the primary irritative zone and the seizure-onset zone in black. So that was done by Shifao. And this is done by the expert then. And then what we generate is from our data. So this is our MEG estimated SEEG. So when you apply the forward model on this, the SEEG, so you get your potential in microvolt, and you see the involvement here, mainly in those regions. And then we did roughly the same, but we could not have a physical model. So we did a projection of the fMRI into the SEEG space using a local sphere. I think it's a sphere of radius 1 centimeter. So if we have a t-value in fMRI within that region of the electrodes, we project it there. So now we have MEG and fMRI here, our gold standard there, so we could compare that. And we compared them in terms of spatial overlap by computing area under the RC curve to see if this area is close to 1. It means that we have a very good spatial overlap between those 2. And then we also measure distance with specific point. So either we look the point showing the spike onset or the spike maximum amplitude in SEEG, or for the seizure, what we call the seizure core, which is the channel showing the largest epileptogenicity index. And we measure those. So I'll go through a few examples now. So here is an example of a patient with a right posterior temporal epilepsy. So this is what we reconstruct from EEG MEG. This is what we put in the SEEG space. So this is MEG in the SEEG space. And you see the black ring, the seizure-onset zone, and the yellow ring, the primary irritative zone that was nicely coherent here. And this is what we get from fMRI. Please note, it's not always the case, but in this case, the fMRI result was a negative bolt result. So you have a spike, you expect perhaps increase of activity, but it was a decrease in activity. And we have that, I'll come back to that. So this is our gold standard. So this is the SEEG signal, average spike, and this is the spike estimated from MEG. So this is what we actually measure. This is what we reconstruct, quite similar. And we have the seizure here. So here we have a nice overlap, a better overlap, spatial overlap between MEG and SEEG than fMRI. And then we can measure distance. I'll show you another example here, a bit more complex, as you can see here. So this is MEG. This is fMRI, again negative in that case. The reconstruction, a little bit less accurate, but still interesting. And here we get a better overlap with fMRI. You see that fMRI covered very nicely the seizure onset zone, not that much the primary irritative zone, which in that case was quite extended compared to the seizure onset zone. And another example like that, I'll go a bit quickly. So to summarize what we get, first, here I'm showing you the spatial overlap, so the area under the rod curve, as function of the distance to the spike maximum amplitude. And what we found is that when we localize closer to the SEEG finding, the spike of maximum amplitude, we also get a very good spatial overlap, which is kind of expected, but we found that. And then we classified our data into good spatial overlap or bad spatial overlap, using, I think it was an AUC larger than 0.7. And then when we do this, what we find out is that we found a change between, a significant change between those two patients, mainly for the spike maximum amplitude. So basically, if you have good spatial overlap with the primary irritative zone, our spike maximum amplitude channel was well localized. And then we did the same for fMRI, and we found the same pattern of fMRI, but not exactly from the same zone. I'm not showing all the case. We found this pattern, but for the seizure onset zone, not from the primary irritative zone. And then when we label good and bad overlap, it's with the seizure core. So what was interesting in this study, and that was quite new, I would say, so the first thing was not new, was that EEG and MEG were localizing very well the primary irritative zone where spikes are generated with good spatial overlap. That was kind of expected, but what was new is that EEG fMRI localized also very well, but rather the seizure onset zone. I remind you, we're not measuring seizure in fMRI. We are measuring the hemodynamic response to the spike. But what we can say is that we have mechanism that even when you have a spike, the region that consumes most oxygen or where you have largest blood flow increase is going to be the same that the region involved during the seizure. So we are dealing with two complementary informations, and we have a very good overlap. Then we moved a bit further away because you can always argue that SEEG is good, but is not looking everywhere. And also SEEG is, so you can also only validate results where you have the electrodes. So we use more or less the same data, a bit more data, and this time we compare to the surgical cavity. So what we did, so this is Shifao and Edouard, we did that. So we have the MEG data, the EEG fMRI data, and these are patients who underwent surgery for whom we have a post-surgical outcome, at least 1 year follow-up, and we have a post-surgical MRI. On the post-surgical MRI, we segmented the cavity, and then we co-registered the cavity on the original pre-surgical data. So we could use this as a gold standard. This is only a gold standard when the patient is seizure-free. So if your localized was in the resected area, that's a good sign when the patient is seizure-free. So similar inclusion-exclusion criteria. So from 37, we ended up with 29 patients for that study. So few had technical problems. So 26 had both EEG, significant EEG MEG results, 17 EEG fMRI, and 15 had both EEG fMRI and EEG MEG results. So the method here is start as the other one. We select similar spike in MEG and EEG fMRI. We localize them. So this is the MEG, EEG MEG consensus map I was showing you. But this time, I define the surgical cavity and I overlap in green the surgical cavity to my source map. So I can compare those two. Same for fMRI. You get your fMRI map. your most significant cluster, which was a negative cluster here. And then the color is not perfect, but this magenta color is actually the surgical cavity that was marked here. And then from those, we can compare metrics. So what are the metrics? We measure distance to the cavity. So we call that distance localization error. We measure overlap, spatial overlap with the cavity. So area under the ROC curve, knowing that I don't know if it's good to have exactly the same size for the extent of the MEG or fMRI and the cavity. It's probably an underestimation. And we estimated positive predictive value and negative predictive value from that. And so again, few examples. So this is a patient who is seizure-free. So the localization is well here, and we get a good localization of MEG here. And the negative fMRI cluster was also very closely related to that cavity. This is another patient who is non-seizure-free. Here, what you can see is that the MEG was a little bit off, a little bit more further away. And in fMRI was completely off. The most significant cluster was really completely out in that case. There was another cluster that was more closely related, a negative one closely related here, but the most significant one was very far. Another one, which is seizure-free. So we have a MEG very well localized in the focus. fMRI, we had two focus here. So the most significant was far, but the second one, that's why we are not sure we're going to use only the first one, was very well localized. So these are our very last result on this study. So what I'm going to show you for different metric, I'm going to show you EEG MEG source imaging and fMRI for non-seizure-free and seizure-free patients. So here it's the dipole, the distance localization error. So how far was our localization from the cavity? And you know that for seizure-free, as expected, the distance was lower. So indeed, we have a lot of zeros, so a lot of localization were in the cavity. And same, it did not reach a significant threshold, but similar pattern with fMRI. Then we looked at spatial overlap. And spatial overlap, you know that for non-seizure-free, our area under the ROC curve was at the chance level, so was at 0.5. So like the spatial overlap between our cavity and our MEG localization was really at the chance level. But you have to remember that those patients are not cured. So probably this cavity was not. So we cannot say more. What was really good is that we significantly increased this spatial overlap for seizure-free patients. With the median AUC was at 0.73. So that was quite good. And we have similar patterns again for fMRI. A bit lower, but similar patterns. And we see also the same factor for positive predictive value and negative predictive value. So this is for localization of spikes. So I think, and these are useful clinical tools that we are using in clinical practice, that you have a patient localizing the spike in EEG MEG or doing EEG fMRI and taking the most significant clusters are definitely clinically relevant. And these are not the only papers, but we are showing you two nice illustrations that this is useful. Now the next steps is what can we do if we don't have discharge? Or are there other aspects that we can measure on those patients using resting state patterns? So we're going to look at resting state connectivity. And I'm going to apply resting state connectivity on those two modalities. So either resting state fMRI or resting state MEG. So on resting state fMRI, I will talk briefly about this technique developed by a former student of mine, Kang-Ju Lee, who's now a postdoc in research associate now in Yale. And she developed this method that we call SPARC. So it means sparsity-based analysis of reliable K-hubness. So it's a sparse technique to extract the hubs of those epileptic networks. So these are what we are looking for. We've heard a lot during the past few days that the brain is organized as networks that are communicating to each other. And you have key connections, sometimes called the Rich Club, which are some hubs that are connecting different modules, different networks together. And those are very important points. And they are characterized by a high number of connections. They participate to between network communication. It's been shown that they are efficient, so it's part of what we call the small world organization. They are also associated with efficient brain metabolism. So if you look at glucose metabolism, it does not increase linearly with the amount of hubness. You have a plateau effect, and we have shown that. And it's also vulnerable. So if you attack specifically those regions, you're going to destroy the network structure. And it has been shown that this is changing in pathological cases, notably in epilepsy. Standard technique to estimate hubness is you start with what we call a connectome. So you take a bunch of regions, an atlas, and you do the correlations between those regions. And then one metric, that's not the other one, there are more fancy metric, but the first one was you take one line, use threshold, and you count the number of connections, which is what we call degree centrality. But that measure is sensitive to multiple collinearity. If A correlates to B and B correlates to C, A is going to correlate to C. And it's also biased by the size of the network. So, and once we have a degree, so if I see that this point is a hub with large degree, I don't know exactly what networks are involved in that hubs. And this is what we try to propose with this technique called SPARC. So in a nutshell, it's a sparse decomposition. It's a data-driven technique. It's not so far from an ICA decomposition, but slightly different. So from resting state data, we're going to estimate what we call atoms. These atoms are specific time course. So it's an iterative technique. We're going to look for this time course in the data. And then from this time course, associated to each of those time course, I'm going to have a map. So in a way, this is a decomposition not far from ICA with a time and space decomposition. It's just that the way to estimate it is different. It's not based on independence. But you see your favorite network, the attention network, default mode network, visual network. And you also have few artifactual networks to remove. But then the main idea to measure hubness is that to model the activity in one voxel, we're going to estimate that the activity in this voxel is a sparse decomposition of the time course here of only 3 of those networks. So let's say we have a maximum amount of 20 networks, and we're going to look for a decomposition by imposing sparsity. So I want to have the involvement of 1 network, 2 networks, 3 networks. So I have a small number ranging between 1 to 6 or 7. So it means that this voxel has a hubness value of 3. The red voxel here has a hubness value of 2. And when you plug all that together, you get a hubness map like that with value ranging from 1 to 5, for instance. And what we show, so this is the only way. So this is based, the main algorithm behind that is what we call KSVD. So the idea is we are really fitting the different time course in this X matrix using a constraint on sparsity that has to be defined. I will not say more about that, just showing that first we evaluated test-retest reliability on those techniques. So this is a data, this is a New York test-retest data set. So 25 subjects who's been scanned 3 times, those between 5 to 16 months away, and this 30 minutes away. And at the average level, you get very similar average hub maps on those 3 sessions. So it was at the group level very reproducible. And if you go closely, this is the sparse code matrix. So if I look at the posterior cingulate, here you have all the voxel of the posterior cingulate, and here you have the network. And what you see is that you see mainly 2 networks involved in the posterior cingulate. And these are those 2 networks involving the default mode network clearly, with this second one involving the hippocampus, not the first one. And this was for 1 subject in session 1, and it was actually reproducible with the 2 other sessions. So we found those similar aspects. So it's reassuring. And then we applied that to epilepsy. So here, this is the very first study we did on epilepsy using standard seed-based correlation. So we're talking about temporal lobe epilepsy. We do EEG fMRI. We select runs with very few or no spike, so resting state. And what we did, we marked the hippocampus on both sides. We do seed-based connectivity, so just measuring correlation. and we are comparing that in patients compared to healthy controls. And in this first study, more than 10 years ago, what we found is we find mainly a decreased connectivity in the patient. So the patients were showing decreased connectivity mainly with the ipsi and contralateral hippocampal regions that you see here, but also within the default mode regions, and notably within the posterior cingulate. And we wanted to evaluate that on hubs. Like, do those regions are showing reorganization in terms of hubness? And it looks like yes, because here we propose a metric to measure what we call the hub. This is the hub distribution index. So the hub distribution index, if it's negative, it means that when you have hubs in healthy controls, it becomes non-hubs in patients. So basically, you plot hubness in the controls, hubness in the patients, and if you have a negative slope, it means that you had hubs that are becoming non-hubs. So of course, it's around zeros in controls, so it doesn't change. And for left and right hippocampus in left and right TLE patients, we see a decrease. So we see that there are a loss of hubness in those hippocampal regions, which was in agreement with, of course, our seed-based connectivity. So that was interesting. And something new that we found is we looked also at the hub emergence index. Are we creating new hubs? And it turns out that it's only in the right temporal lobe epilepsy, not in the left temporal epilepsy, that we are creating new hubs. So we are, and this was actually in concordance with an EEG study showing that we have abnormal bilateral connections more in the right TLE than in the left TLE. So that was interesting. And this is another example of what we can extract from those maps, because you have those hub maps. So this is for single subject, but you know exactly what are the network involved. So for instance, if I look at this right patient, you have the normal, so this is the normal, hippocampus is the left one. And you see that you have a large involvement, for instance, of the default mode network connected with the hippocampus together with the salience network and the temporal network. Now, if you look at the hubs of the right TLE, we have only 1%, so we are completely losing the default mode network. And this is the same kind of idea with left TLE, where we are only losing, we are not getting new networks. So this was for connectivity for fMRI in connectivity in fMRI using this technique, and we are currently analyzing more data. We have work ongoing with Dr. Boris Bernard, where we plan to correlate this also with diffusion MRI data. And can we do something when we have data at rest in EEG or MEG? Can we extract something from the rest? So I show you that this morning, saying that if you look at the envelope, the correlation of the envelope of your signal, you have a structure of interest that looks, it's been discussed, and there are contradiction results so far recently, but it looks like you have pattern that looks a little bit like fMRI network, not similar, but there is clearly a structure. So this is, you filter, you reconstruct your data, you filter in a specific band, and then you correlate the envelope. So you can do seed-based. So what we did is we tried that using MEG. So first you can ask whether MEG resting state localization is accurate. And I think I did not remove it. I still have some slides of Jawata, so I will skip them. But Jawata has shown that when you compare MEG resting state localization with the intracranial EEG atlas, you have a very good comparison. So she's using the SEEG atlas developed by Birgit Frauscher. And this is a multicentric data where you have the data from different groups, only the normal non-epileptic channel. So this is the coverage. And what Jawata has been doing, so you have the data from the atlas, 1 and 10 patients, 2,300 channels, 60 seconds of resting state. This is our ground truth. And then we took MEG data from 45 subjects, applied wavelet MEM in different frequency band, and then projected those data into this SEEG space using the method I showed you before. I apply the SEEG forward problem as in the neurology paper. And then we can compare the overlap there. And some of the finding, one was for some regions, the overlap between SEEG in black and MEG in orange, it was very good. For other regions, like typically in the hippocampus, we get wrong or spurious alpha localization. So I'll stop there. And this is my last study. I'm going to be done. So we are able, mainly cortically, perhaps not on deep cortical, on deep structures, but on the cortex, we're able to localize resting state activity and the power of resting state activity relatively accurately. And so in this study that we did with Umitaidin, we wanted to assess whether we can predict or whether we have patterns of resting state connectivity that could allow us to predict surgical outcome. And the idea is that, of course, it's a huge problem in epilepsy because even if we are improving in our presurgical mapping, still many patients are not seizure-free after surgery. 53 to 80% for temporal mesial epilepsy and 30 to 76% in neocortical epilepsy. So are there markers that could allow us to find out some procedure? So here we are doing this hypothesis. We're going to look to resting state connectivity with the presumed focus. And what we're going to say is that if I have a focus that is here, and if this focus is getting isolated, so during resting state, when there are no epileptic activity, if this focus is isolated from the rest of the brain, then probably removing that focus will be good and beneficial for the patients, and it's going to become seizure-free. But if during resting state, this focus is already having a lot of long-distance connections, then removing it might transfer the epilepsy somewhere else, and that's not good for surgical. And that's what we assessed. And to do that, we use this famous amplitude envelope correlations proposed by Brooks, and we selected data with no spikes. And we are comparing seed-based connection with the focus and seed-based with the contralateral regions, and we were comparing those. So I have very few slides left. So first, we localize the focus as I showed you at the beginning of this talk using spikes. So I have this localization. Then I define the focus. I define the homologous contralateral area. And then I use those two regions to do seed-based connectivity. So I localize resting state ongoing activity, typically in the alpha band. I take the envelope of the alpha band using Hilbert, and then I'm doing correlation of this envelope. I'm orthogonalizing it to remove the zero lag. And so if I take this, I take different points in my focus, I get a connectivity map for every point. I get a connectivity map for all the points on the contralateral side. And then I'm comparing them using a t-value and a threshold t-value. So I'm getting with what I call the laterality map. So this is not comparing a patient to a database of control, which is what we're trying to do now. This is comparing a patient with himself. Of course, it works for purely unilateral epilepsy. It doesn't work for bilateral epilepsy. And here what you see is the laterality map. So when you see that it's red, it means that those regions were more connected to the focus than to the contralateral regions. And when it's blue, it was actually more connected to the contralateral regions. And we use that as a metric to try to clarify. And we summarize that as a laterality index. And that's exactly what we found. And if you look, so it's a preliminary study, it's not a lot of patients, but if you look on those two, you see that perhaps except that case, we have mainly blue results on that side. So basically more connectivity with the contralateral regions, like a compensatory mechanism and isolation of the focus, and they were seizure-free. On the other case, we get a lot of blue here on all those cases that were non-seizure-free. So we see that there were still, during resting state, long-distance connections, and removing that was not a good idea. And perhaps we could think of other way to treat those patients. Of course, we need to further validate that on more patients, and that's what we are trying to do for the moment. So I will just show you two examples. So these are the data I showed you for the cavity project. So we have the data for the cavity. where we are comparing the bold response and the MEG sources to the cavity that we do. But on the same subjects, what we are doing now, we are doing the hubness map with fMRI, and we are doing the laterality map with MEG, and we try to put that together. So this is where we are right now. So I will just show you two examples. One seizure-free patient. So you get an example here. You get the localization of the sources right in the cavity. So the cavity is in red. fMRI, we were just below the cavity, but not so far in fMRI. And when you look at the connectivity map in red, in MEG, so the laterality map, again, it was more bluish, I would say, than red. So more compensatory connection, so more connection on the contralateral case. And when you look, it was not clear, but when you look on the hubness, we see slightly less hubs or similar level of hubs between those two hemispheres. So this is very early results. So this is all going into the direction from a multimodal perspective. We have good localization of the cavity, and then the patterns of connectivity are in agreement with our assumption that this patient should become seizure-free. And then the case where it was not working, so the localization was not that bad, but not perfect. So for instance, the MEG was localized there, but the cavity, the surgery was a little bit more posterior. Perhaps it would have been better to operate here, but I don't know. I cannot say that for the moment. fMRI was a little bit closer with an extended positive cluster, but not so far. But when we look at the, so this is for the localization. So we were close, but not perfect. But again, it is not operated. But when I look at the probability with the cavity here, there is way more red here and some extended red regions like connections from here. So that was not a good sign according to our previous paper. And when you look at the hub map, it's not very clear. And analyzing hub maps is difficult because these are discrete value between 1 to 5. And what you find out, it's a tiny point, but you see a point here, which is a hubness of 4. And that's really a lot. And a hubness of 4 means that we have interaction between 4 networks. It would have been interesting to look what are those 4 networks. We did not do that yet, but this is in the cavity, we have this intersection. So again, we are dealing with a cavity that is showing extended long-distance connectivity, and removing that was not beneficial for the patients and is not seizure-free. So now we are analyzing that on more patients. These are just 2, and I'm going to stop there. So I'd like to thank the whole team on that, and especially like the main people involved in that work were mainly Shifau Abdallah, Umit Aydin, Rashida earlier, and now also Jawata and Edouard. We have Ariel and Hassan on the connectivity part. Thank you very much.
No, thank you very much, Christophe, for this very important piece of research that your team is doing. And let's open the discussion. And any question for Christophe? Okay, so let me start. You show us that there are a few herbs that you are going to lose, and other herbs that you are going to create. Okay, herbs that we lose, this is something that it's more understandable in my mind, because we have the same problem with neurodegenerative disease, and we try to understand why we lose this kind of herbs. With some other diseases, we observe also losing herbness, but not even creating ones. So what does it mean having
we're not the only one showing that, because it's been shown from the structural point of view. So yeah. I have not do research on that, but there are reorganizations of the epileptic brain, and that shows that here we found, so typically what we found is we found preferred new connections between the temporal lobe and the salience network. And that was something new that does not exist that much in the healthy subject or in the left temporal lobe epilepsy. We need to confirm that with more patients, but it's really that the network has been reorganized. So what are the causes of that? Of course, there is the epilepsy disease. There are probably also the fact that it's generating seizures that have preferred pathway and that could facilitate specific territory for blood flow and something. But what does it mean? Do we have an anatomical substrate for that? Like, was it already there, but it's more used? Was it a new anatomical substrate? I don't know. That's why we would like to compare that. We would like to extend that a little bit more, because in this study, it was really hypothesis-driven. So we looked only at the hippocampus. Actually, we looked a bit at the posterior cingulate as well, and we found also interesting results. Now with Ariel, we are trying to look at these patterns of hub emergence and hub disruptions on all the different regions within an atlas. And our idea is to find perhaps a fingerprint of the epilepsy disease. Where do we see increase? Where do we see decrease? It's not that easy because our method is also sensitive to some level of noise. And when the method is not reliable enough, I will say the hubness is 0 because I don't get man. So we need to handle what's going on when we have too many zeros. So that's one of the pitfalls of the method right now. Mm-hmm. But it's clear, like the usual patterns, the main patterns is definitely hub disruptions, but there are few hub emergence. Yeah. And it's been suggested from the anatomical point of view, from using diffusion in some study. I'm not exactly aware of that literature, but it is a possibility.
Yeah, I just mentioned this point because, or maybe there is no. Okay, few years ago I worked with Hugues Dufault at Pitié-Salpêtrière Hospital in neurosurgery, and when we extract some areas from neurosurgery, what he know. This is before we did fMRI data. What he know is that extracting some area, we have like an emergence of other area, and often, I mean, symmetrical areas, but usually area within the same network.
Yeah, but this is pushed by the surgery.
This is pushed by the surgery.
Here I'm talking an effect.
Absolutely.
I'm talking about an effect of the epilepsy,
yeah,
which is probably related. Well, there are many people showing different kind of patterns, but most of those things, when you correlate with the epilepsy durations, like the age on onset of the epilepsy or the frequency of the seizure, all those parameters are correlated. So the change in hubness are really changing that. The change in hubness are really impacting really like the change of epilepsy, like the epileptic activity is changing the network structure at all.
Okay, my question is those areas who emerge like hub that does not exist before are within the same network as the one that you lose or not?
For in like the only case I will mention where we reported something is hippocampus. Mm-hmm. And in the hippocampus, we've seen that. And we've seen that in these studies, as I said, we tried to look at more region now, but in this first study, we look only at the hippocampus. And what we found is that it was really a typical disease, like left temporal epilepsy was only disruption. Right temporal epilepsy was disruption. So basically in right TLE, you still see the disconnection between the hippocampus and the default mode, but you see new connections between the hippocampus and the salience in mesolimbic regions, notably. And that it was, we need more patients to see that, but that was really specific. And that also raised questions because sometimes to have better statistics, imaging people are assuming that right and left temporal lobe epilepsy are the same. And what they do is they flip the image to have more statistics. What we are saying here is they are not the same pattern at all. So you should not flip and mix them as if they were just a mirror one from each other. They are not.
Okay. So I have one question on this, or close to this. because what you did is looking at the seed based on the focus of the epilepsy, and then looking at the connectivity from this seed base. And you took the mirror of the seed base and you do the same.
Yeah.
So well, do you get a network who include both sides? I mean, from the seed, you have the connectivity over the whole brain, or is it only in one hemisphere?
It's not that clear that you get both sides. We did not measure that. We did not try to threshold that, basically, because we are also, even if we do the orthogonalization, we are also sensitive to the leakage, what I was showing this morning. So basically, the most of the connection is local. Most of the connection is around your seed, and then it spreads. So how much? So I don't think I have seen that, like connections that involve those two networks. Also, we know they are related, and we studied only one metric here. We study envelope correlation in the alpha band, or we did in the beta band as well, which is a particular beast. But if we look at phase, we might probably see completely different patterns. And actually, we're interested in getting there.
Okay. In any other question?
Just one comment. Well, I understand that that's not your favorite plate, but while you are at the multi-modal level for seizure-free, didn't you want to use like other kind of information, like health information, biochemistry information for the patient, and so on, whatever, genetic information?
This is like, especially if we want to build predictor of seizure outcome, they're like what we showed here is that those patterns seems to be correlated with seizure outcome. That's it. We did not show more. And to build a predictor, of course, we know that there are other important informations that could predict surgical outcome. And it might be because the database was too small. It was just by chance. So the presence of a lesion, there are different kind of patterns. And so we need to do that carefully. And we hope to have more patients to investigate. If I would like to build a predictor using machine learning technique, for instance, I can build a predictor using standard measures, like standard clinical measures that we have, and add on top of those metrics to see if they really make the difference. And that's the only way we could do it. So for now, it was just an idea that there seems to be a structure of interest, but we cannot say more.
Okay. Maybe you can comment a little bit on one result that you got, and I don't understand completely. The fact that EEG fMRI is more sensitive to the peak of epileptic discharge. That's what you see. And EEG fMRI is more sensitive to the seizure onset. So, okay, what does it mean? And can you explain? Because I know the modalities, but what does it mean from the
so that was actually, I think that's probably the reason why we got this published there. So this is the finding we have here. And actually, it's very interesting. So the first part is logic. So the primary irritative zone in SEEG is where the spikes are generated. You use MEG, you localize spike, you hope that you find the same region. That's fine. But a priori in EEG fMRI, you detect spike, you localize the hemodynamic, you should have the same. Okay. But actually what we see is that, and there is an overlap, but not a perfect overlap between those two. So the interaction between spike and seizure is something complex. Sometimes people tend to say that spike are there like more as an inhibitory protective effect to avoid, and when they are not there, you have the seizure. It is one of the ideas, not the only one. And yeah, so that, and what we find out is that the hemodynamic response, so the metabolism, is more intense where you have the seizure onset zone, where more likely you have the more pathological neurons, which will end up in consuming more energy. And it's not exactly the same region. And that's also the same reason when Jean was talking about the spike onset zone, which is typically you have a spike that generates in the hippocampus, propagate to the scalp, and then you measure the EEG fMRI. You get a bit of the lateral regions, but you get mainly the origin. So this is also the change between the two modalities. We have one modality that is sensitive to metabolism and blood flow, and the other one that is sensitive to synchronization of neuronal activity. And Meg, you will see a spike when they're going to be highly synchronized. But it might be that they are highly synchronized here, but they might have the generator here that consume more energy here, which seems to be in the seizure onset zone, even if you don't have the seizure yet. And once you have the seizure, it's been reported EEG fMRI during the seizure, you get a very, very strong response there. But
okay, so this is the gap between the
and
synchronization
of
neurons
and metabolism.
Metabolism. This is your explanation.
I think it's that. Okay.
Makes sense. Any question? Even for the team? It's the good opportunity for the team to ask. Okay. No? Okay. So if there is no question, so I just would like to thank again Christophe for his nice presentation and the nice discussion. Thank you very much.
Thank you.
And this and the week.